oxyhemoglobin dissociation curve is a graphical representation that shows the relationship between the oxygen levels in the body and how easily it combines to hemoglobin. And when they are bound to hemoglobin, it's called oxyhemoglobin. So therefore, you're looking at your saturation versus your oxygen levels. So it just talks about how easily oxygen unloads at the tissue based on its affinity for hemoglobin. So here we have two different portions of the curve. This is what we call a sigmoid or an S shape, curve. So at the beginning, when we don't have much oxygen in our bodies, any added oxygen will cause a really steep portion of this curve. And that's because of hemoglobin's ability to bind called cooperativity. So therefore, if a little bit of oxygen starts jumping onto the hemoglobin, it changes its biochemical configuration, and it allows for more oxygen to bind to the hemoglobin. Then when we get up here, to this flat portion, so when we get up here closer to normal, you'll notice that the curve starts to plateau out. And the significance for that means that you can add more oxygen to the body, but it isn't really going to bind anymore to the hemoglobin. So it doesn't really matter. So in that case, that's our body saying we want our tissues to get a lot of oxygen. So therefore, we want the oxygens to be bound to hemoglobin, but too much isn't going to be beneficial. So then we have different shifting in the oxyhemoglobin dissociation curve based on different physiologic conditions. So when we talk about shifting in the curve, we're talking about how easily it is for oxygen to bind to hemoglobin. So if we have a right shift in the oxyhemoglobin dissociation curve, that means oxygen will have a less affinity for hemoglobin. And so therefore, oxygen will easier jump off onto our tissues. When we have a left shift, that means that the tissues don't need as much oxygen, and so hemoglobin and oxygen will have a higher affinity for each other, and they'll bind stronger, and so the hemoglobin won't release the oxygen to the tissues as easily. So different conditions that will shift our curve to the right, meaning oxygen will more easily go to our tissues, would be if your blood is more acidic. So therefore, we have a higher hydrogen ion concentration, and that comes from carbon dioxide. So more carbon dioxide will have a right shift where our tissues will say, I need more oxygen. This here is called 2,3-biphosphoglycerate, and this is it is a molecule that gets released with red blood cells. And then temperature. So take, for example, if we're febrile trying to fight an infection, or if we're exercising, and that's why the picture here has this guy lifting weights, we're going to have a right shift in our curve. And that's going to say, hey, our tissues need more oxygen. One of the things that's interesting here in Denver is, I said before, we live in a hypoxic environment. So we have some physiologic processes that help us survive here, and not just survive, but thrive here. So one of them is we breathe, our respiratory rate, we breathe just a little bit faster. So therefore our carbon dioxide is just a tiny bit lower. And if you remember the alveolar equation, carbon dioxide is something that contributes to that. So if we have a lower carbon dioxide, the alveolar oxygen will increase a little bit. We also make more red blood cells. So therefore, we have a higher amount of this 2,3-biphosphoglycerate product. So therefore, we have a right shift in our oxyhemoglobin dissociation curve. So that just says that at a certain level, so when we have a lower oxygen level, our hemoglobin won't bind as much, and so it will release those to the tissues. So even though we're starting out with a lower oxygen pressure, it gets to our tissues easier here at altitude. So the left shift, we just talked about that. Okay, the left shift makes it harder to unload, and that would be a decrease in this 2,3 VPG temperature, or if we have an alkalotic condition, a lower concentration of hydrogen ions or carbon dioxide. So that just means that our body doesn't need, our tissues don't need the oxygen as much. Carbon dioxide is a lot simpler. There's no sigmoid shape to the curve. It's just a pretty direct linear curve. So the more carbon dioxide you have, then the more amount of carbon dioxide in the blood or the content you're going to have. So there's no physiologic conditions that allow it to bind easier or not as easy, except for something called the Haldane effect. And the Haldane effect talks about how oxygen affects carbon dioxide dissociation with hemoglobin. So when deoxygenated blood is present, will enhance or increase the unloading, it'll enhance the loading of carbon dioxide on red blood cells, on the hemoglobin. And then the Haldane effect works another way. Oxygenated of blood will, when it's oxygenated, it'll say, okay, carbon dioxide, you need to be released. And so that always kind of works together to help for us to get the oxygen we need to our tissues and then release the carbon dioxide easier based on our oxygen levels. Okay, so I have a really good video that's posted here. I'll have you guys watch that talks about all of this. Now we're going to go on and talk about something that we started talking about in chapter 2, which was ventilation. We're talking about dead space. Dead space is wasted ventilation. It's ventilation without perfusion. However, we have another whole spectrum to that, and that's something called a shunt. So a shunt says, okay, unlike dead space, there is perfusion, but there is not ventilation. Okay, so shunt is opposite to dead space. Shunt says there is perfusion, but there isn't ventilation. So we're going to talk about both of those. So there's different types, same as there was different types of dead space. There was anatomic dead space, which is the amount of gas that's in our tracheobronchial tree that's not participating in gas exchange. And then with shunting, there's the same thing. There's true or anatomic shunts, and that is the portion of the cardiac output that does not exchange gas. 3 to 5% of the total cardiac output, which is 5 liters per minute, does never exchange gas. So it's just a portion that completely skips gas exchange altogether, and that's anatomic. That's normal. We can't change any anatomic shunting. Then we have something called a shunt-like effect, or the capillary shunt, and that's where blood that does exchange gas, it does take place. However, it's not enough to make normal PaO2. Okay, so it's just like when we had the dead space and we had that physiologic dead space. There's anatomic and physiologic. This is the same thing. It's not that it's anatomic and it can happen, but it's just that it's not working as much. So what that would be like is in a clinical condition such as atelectasis, where there's a collapsed lung unit, that's just not exchanging enough gas to get to that normal value that we need. Two things. When we have an anatomic shunt, we say that it's refractory to oxygen therapy. So if you have a true shunt, oxygen will not work. So that's anatomic. And then if somebody has like a congenital heart defect, that's one way that you can kind of see right away. So let's take, for example, if a baby is born and they're blue and you give them oxygen and they don't respond at all, perhaps they have an anatomic shunt. Whereas a capillary shunt or a shunt-like effect means if you give them oxygen, that will help. That will help them because you're getting more gas flow to that area that does have perfusion. So shunting, we just said it indicates the ratio of shunted blood to total cardiac output. It does talk about the efficiency of the pulmonary system. Normal values are 2 to 5%. 10 to 20% should have minimal effects on respiratory homeostasis. 20 to 30% indicates significant pulmonary disease, so intrapulmonary shunting. If greater than 30% of your patient's total cardiac output is a shunt, it is fatal. So you're going to hear the term venous admixture, and that just means a mixing between non-oxygenated and oxygenated blood. So it's just a mix. And it will lower the arterial oxygen pressure. Normal value for a PaO2 or arterial oxygen pressure is 80 to 100. 60 to 79 is considered mild. 40 to 59 is called moderate. And less than 40 torr of oxygen is severe. And the term we're going to use for that is hypoxemia. So normal, mild, moderate, or severe hypoxemia. So let's dive right into hypoxia. So hypoxia is when the amount of oxygen available for cellular metabolism is inadequate. So just from reviewing again from this lesson, oxygen is transported mainly on hemoglobin, and 3% of it is dissolved in plasma. And the whole goal is to be transported to the tissues where they're going to uptake approximately 250 mils of oxygen per minute. And that's based on the delivery or the amount that's available to the tissues. And that's about 1,000 mils per minute. So that's about, our bodies take up approximately 25% of what's available. Then via cellular respiration, our tissues make carbon dioxide, transport the carbon dioxide molecule, same thing, mostly on the red blood cell, but also dissolved in plasma. And then the majority of it is attached to bicarb. And then that gets taken back through the lungs and exhaled out through ventilation. So there's different types of hypoxia. So the different types are hypoxemic hypoxia, histotoxic hypoxia, anemic hypoxia, and circulatory hypoxia. And then when we look here about hypoxemic hypoxia, there's 5 different types. There's when there is low alveolar oxygen, and that happens when we are at altitude and there's not enough barometric pressure. So that's the first type. Second would be hypoventilation. So hypo means low, and then ventilation is the physical process of bringing air into the lungs. If a patient is not ventilating, they're going to have low oxygen levels because they're not bringing that into their lungs. The next type is what we just talked about, a shunt. So there's perfusion coming by, but for some reason gas exchange isn't taking place. So that could be an anatomical shunt, or that could be a shunt-like effect or a capillary shunt, meaning there's just not enough oxygen to exchange. We could have a diffusion defect. So a diffusion defect could be something like alveolar fibrosis, pulmonary edema, pneumonia, anything that's causing a thickened alveolar capillary membrane. Then we could have something called VQ mismatch. So we've talked on multiple occasions about Ventilation's normal amount is 4 liters per minute. So that's your minute ventilation, 4 liters every minute. Cardiac output is approximately 5 liters per minute. So we need that normal 4 liters per minute of gas exchanging with 5 liters per minute of cardiac output. If either one, your minute ventilation is low as compared to your cardiac output, or if your cardiac output is low compared to your minute ventilation, we're going to have a mismatch at that alveolar capillary membrane, and that's going to cause hypoxemia. And that's the number one cause. Just something's wrong with your ventilation or your cardiac output. So once again, different types of hypoxia: hypoxemic, histotoxic, anemic, and circulatory. Histotoxic hypoxia is generally from like cyanide poisoning or some sort of gaseous poisoning in which it kills your tissues. So there's not a problem with the amount of oxygen in your blood. It's just that the tissues are damaged, and so they can't uptake the oxygen. Anemic is just what it sounds like. So there's a low hemoglobin and hematocrit in your blood. So there's not enough of the carrier molecules to take the oxygen to the tissues. And then finally, circulatory. If a patient is bleeding heavily, or if they're pooling blood where they're not meant to pool blood because of some sort of chronic cardiovascular or an acute cardiovascular incident, then the blood, the cardiac output is not appropriate enough to carry the oxygen to the tissues. So those are the main types of hypoxia. So if we're saying, does my patient have enough oxygen? We have to look at different layers. We have to say, okay, let's look at our PaO2, our arterial oxygen pressure. First of all, is there enough oxygen pressure in the alveoli? And how is the alveolar capillary membrane? Does that have a good integrity enough for diffusion to take place? Then we can say, well, how's our saturation? So how is the amount of oxygen combined with hemoglobin? That is determined by, one, is there enough oxygen pressure to bind to hemoglobin? And then our physiologic conditions. And then finally, our CaO2, which is our content of oxygen, and that's the one that we consider most accurate, meaning it's just the best global indicator because it takes into consideration the hemoglobin values, the saturation, and the dissolved portion of oxygen. So, as I said, that all of those factors have to be present and be adequate enough for us to say that our patient has the appropriate amount of oxygen. So in summary, oxygen is transported 2 ways: dissolved and bound to hemoglobin. Carbon dioxide is transported 6 ways. Most of that is carried via the bicarbonate ion. PaO2 is the amount of arterial oxygen dissolved in plasma, and it's a good indicator. It's not the most accurate, but it is a good indicator of the patient's status. If that's low, that's called hypoxemia. The SaO2 and oxyhemoglobin dissociation curve talks about how easily it is for oxygen and hemoglobin to bind. CaO2, or the content, is the best overall indicator of the oxygen available in our body. Shunting is when there is perfusion but not enough ventilation, leading to hypoxemia. And then hypoxia has 4 types: hypoxemic, histotoxic, anemic, and circulatory. And that is where your tissues are not receiving enough oxygen.